Good afternoon. Today we're going to talk about the speech component under the patient-driven payment model, PDPM. And hopefully everyone on the phone has heard somewhat about PDPM and the changes that are happening come October, some of you more than others. Effective 10/1/2019, the methodology for Medicare payment is going to change. Reimbursement's no longer going to be driven by therapy services, but instead is going to be based on each individual resident's overall clinical picture. So we've all heard that a picture is worth 1,000 words, and under PDPM, a diagnosis is going to be worth $1,000. So there are 5 case mix driven components, and those are added to an additional per diem component that will be used to establish a different rate for each of the individual Medicare residents. So currently a resident could fall into any one of 66 different RUG levels with different rates. And under this new system, there will be 24,000 different rates that the person could fall into based on the combination of these 5 case mix driven components. The case mix driven components are PT, OT, speech therapy, NTA, which is non-therapy ancillaries, and nursing. We're going to talk about speech for the purpose of this training today. So SLP stands for Speech Language Pathology. It is one of the most complex components under this system. Every resident will have a portion of their payment based on where they fall in the CMI tree under the speech component. This is not based on whether or not someone receives speech therapy. So even though they don't have speech therapy treating them, they still will fall into a CMI level, and portion of their payment will be related to this component. So there are 5 different drivers under this speech component alone. All disciplines can contribute to the recognition, documentation, and capture of the most appropriate speech CMI, and therefore contribute to establishing the most appropriate reimbursement rate for each resident. So under the current practice, therapy and late loss ADLs are the only thing that determine the patient's rate. Under the new system, they look to have it be something that is widespread and looks at all the care that's provided to the patient as a whole, and gives us some financial incentive for the other care that we provide outside of just therapy services. So those 5 drivers are acute neurologic condition, and this is driven by primary diagnosis. Your admissions folks, your doctors, your nursing, your MDS coordinator, and your therapy folks are going to collaboratively work on identifying the diagnosis that is the main reason the person was admitted to the nursing home. The other driver is speech comorbidity, and this is driven by qualifying diagnosis, conditions, or services that the patient will receive once they're in the facility. Again, your admissions folks, the doctors, nursing, MDS coordinators, and therapy will look through the medical record to try to identify whether or not this person has the different qualities that will allow them to capture a comorbidity under this component. Impaired cognition is driven by your BIM scores that are under 13. The social work, nursing, MDS coordinators, and perhaps even speech therapy will play a role in how it is that we identify this information. So I know that PTS is perhaps working on a pilot where some speech component is going to be looked at by the therapy, and they will also look at BIM scores. So in the absence of a BIM score that gets completed by a social worker, let's say on day of admission, and the person discharges the next day, we would still have some backup information. What we need to make sure is that everyone who is collecting that data is doing it according to the standards that are set out by the RAI manual. So we need to make sure everybody is cross-trained in that. Swallowing disorder. So this is driven by symptoms of coughing, pain with swallowing, losing food or fluids out of their mouth. And this is where your CNAs, dietary staff, activity staff, and even families come into play, because an MDS coordinator and perhaps even a nurse may not be aware of these things that are happening. So who better to provide that documentation and that insight to us and make sure that we're being reimbursed at every level of the care being provided to this patient, particularly at the bedside where this can often be missed. And the mechanically altered diet, again, a doctor is going to provide the orders for the diet, but often under the direction of a speech therapy who has done an eval or dietary recommendations, perhaps even nursing, CNAs, and activities, again, who have identified that this person perhaps is not swallowing well or is having difficulty with chewing and would benefit from a mechanically altered diet. So if we break each of these 5 drivers apart and talk about the acute neurological condition, you recognize that there are thousands of ICD-10 codes that will collapse into one of 4 categories based on the resident's primary reason for being admitted to the facility and their surgical history that's coded on the 5-day MDS. Hospital discharge and all other aspects of the medical record need to support that determination of what that primary reason is, meaning a resident might have several diagnoses that fall into any or all 4 of the categories, and we can't just choose an ICD-10 because it places the resident in a higher paying category. It's something that we need to look at. They might have 2 diagnoses and either would qualify for why they're coming and getting the bulk of their care with us, but we need to make sure that we're not just looking at 15 diagnoses that the patient has and saying, oh, this one gets us in this case and this gets us in this category, and I'm going to pick this one because it's the highest. That's not the way this works. It has to be what the primary reason is that they're coming to you, and the bulk of what their care will be surrounded on. CMS cautions us that there may be audits and red flags that are associated with these determinations. So you want to make sure that your medical record is very supportive of that decision-making process that chose that primary diagnosis. The second driver being speech comorbidities. And so if you took a look at the MDS coordinators have clipboards that kind of show this to you, you'll see that there are about 12 categories, and each of these categories has a subset of diagnoses that will qualify them for that comorbidity. You don't need to necessarily memorize all those, and some of you on the call probably don't even care so much about this. But the importance of it is to know that dysphagia has many different ICD-10 codes, and one might work and the other one won't. So when you look at this, dysphagia being coded as an I-69 code is going to be following an unspecified cerebral vascular disease, okay? This one that you put down, dysphagia oral stage with an R, is not something that's going to put you into that comorbidity. So if you looked at this MDS and the MDS coordinator coded dysphagia, on the surface you would think, oh, all right, well, why didn't I get that point for comorbidity under this category? And it's because you used a code that didn't bring it to the level that would allow you to capture that. And that becomes the importance of being able to discuss with the doctor. Yes, they have dysphagia at the oral stage, but what is the cause of that? If you remember your guidance for Chapter 18 under the previous education for ICD-10, you would see that symptoms, signs, abnormal clinical and lab findings not elsewhere classified start as your R codes. And the recommendation from ICD-10 is to avoid these and look for the actual cause of that symptom or diagnosis, or sign or symptom. Likewise, laryngeal and oral cancer diagnosis have to be malignant in order to qualify for this comorbidity. So you don't want to think, oh, they have cancer, we're going to get speech language comorbidity. All right, it has to be malignant. So you would, if you know that it is, you look for that specificity in your ICD-10 to bring you to that level and capture that comorbidity. Impaired cognition is the next driver, and this is just a sample of what the BIMS interview looks like. We have spent some time over the last couple of weeks coming out to the facilities and working with social workers and watching how these interviews are taking place, and it's reported that most of them are doing a wonderful job with this, following the script, asking the questions in the order and in the way that it's supposed to happen, and making very good decisions about when it is they should move from an interview and go to a patient assessment sort of deal. So we need to continue with that. And then I need to reinforce the fact that cognitive status, whether it's good or bad, should be reflected throughout the medical record, particularly in the care plan. You don't want somebody with a BIMS score of 3 who's signing their own consents. And likewise, people with a score of 15 who aren't. So you want to look at that medical record as a whole and make sure that everything jives. The next driver is the swallowing disorder. And so when you look at section K of the MDS, an MDS coordinator, when they code this part of the document that will be used to get payment and develop a plan of care for the patient, they need to be able to know that the person has a loss of liquids or solids from their mouth when eating or drinking. How are they going to know that if it is nowhere in the documents and there's no one looking at it? So CNAs haven't told us about it. They haven't told the nurses about it, and there's nothing there. You're going to miss that opportunity, as well as an opportunity to provide care for a patient that's having this difficulty. The fact that the person holds food in their mouth, or they have residual food in their mouth after meals. Think of your 3 to 11 staff who go to put a patient to bed, and this patient has this chipmunk bulk of food in the left side of their mouth as they're going to put them to bed that they haven't swallowed. People now would clean that out, provide mouth care, get them ready, put them to bed, and move around the business. We need to make sure that that is documented somewhere, that there's discussions around that activity that, again, improves the outcome clinically and financially. And that coughing or choking during meals or even when swallowing medications. How many nurses take the liberty of just putting a scoop of applesauce with the medications and thinking nothing of it? You pass meds every day to this particular person, and you know, because you've done that, oh, I always have trouble with this pill. I can't swallow this pill. I can't do this. I can't do that. And you make an accommodation without really thinking much about it. There needs to be documentation. There needs to be discussion around how it is we handle that for the best outcome for the patient. And you might want to consider meal rounds the first week for your Medicare patients. So we probably do a pretty good job of looking at our long-term care people during resident rounds, and perhaps meal rounds that are done separately by therapy. But for our short-term folks, we kind of lose sight of this and we think, well, they're on rehab. If they had a problem, rehab would know about it. If they had a problem, they're on speech, rehab would pick up on it. Well, under PDPM, we have to get rid of that philosophy and that mindset that therapy's handling this and nursing is handling this. We, as a team, need to handle the patient as a whole. And that's what the intent of this system was. So you might want to consider taking a look at that. And I know that PTS has a tool already that they use for meal rounds that they're looking to tweak, and then perhaps we can share that with folks down the road. Again, CMS audits us. Flags, they tell us that there's a possibility of having audit because of the coding that they anticipate seeing increase. And this is going to be related to provider behavior. We have neglected to look at this stuff as intently as we probably should have for a very long time because it wasn't a driver for anything in particular. And like I said, your short-term folks, we often kind of just say, all right, you know, they were fine at home, they did this, they didn't have a problem with this, and we didn't look at this as intently. We will change our systems and we will start to look at these things, and as an outcome of that, as a result of that, CMS will see some changes in this. I don't want you to shy away from coding it, but I do want you to make sure that when you do, all the documentation supports that being an accurate code. And mechanically altered diets. So when we look at this, it's really just changing the texture of food or liquids, pureed food, thickened. It may be due to a swallowing problem, it may be due to a chewing problem, it may be due to a cognitive problem. Whatever it is, as long as, again, we have that documented in the record, you shouldn't be concerned about the potential for increased audit with this, all right? We don't want to see all of a sudden everybody is put to puree because this is a driver. That's a quality of life issue. Even folks who have a dementia diagnosis, we don't just automatically go to puree. All right, people are having weight loss issues. Often we look to see about upgrading the diet so that they would eat more. So we don't want to see that going backwards in response to this change in payment. So if you remember that PDPM is a CMI-driven system, the higher the CMI in each of the 5 components, the higher the CMI or higher the payment is going to be for that particular component. So this is a snapshot of speech and all the things that we just talked about. You can see the 5 drivers: the acute neurological condition, the speech comorbidity, impaired cognition, the modified diet, and the swallowing disorder. Patients can have any combination of those 5, have none of them, have all 5 of them. If they have none of those 5 drivers, they are going to get the lowest CMI in this category, in this component, at a 0.68, and that will still be some portion of payment being associated with the component, but it will be the lowest payment available under the component. And likewise, if someone had all 5, they would be in the highest CMI and receive the highest payment for this particular component. And our patients are expected to fall somewhere in between. So if we were to look at this from a financial standpoint and look at the actual dollars of the impact of this component, sometimes that visual gives us a little bit more insight to what it is we're looking at. So here's a snapshot of exactly what I just showed you, those 5 areas, the category they would fall in, and their CMI. If you were to look at this calculator for speech only, you would see that the lowest CMI, 0.68, this particular patient would be paid $15.52 per day of their rate would be related to speech. If we were to put in the highest CMI of 4.19 for all 5 drivers, look at what that rate did. It went up $80 a day for this patient just by having those. Now, that's an ideal situation to have all 5 of those. The likelihood of that happening is slim to none, but not impossible for sure. So even if we were to look at this and put it back at 0.68, $15, adding just one of these 5 things would bring you up to a 1.46. So you have any one of these and neither of those 2. If we change this to 1.46, watch what happens to the rate for speech. It goes to 33. So it's over double just by adding one of those components. So just identifying that swallowing disorder with the food and liquids falling out of the side of the mouth, or difficulty swallowing with their medications, or coughing, identifying that alone could double the portion of the speech rate. And that's really all that I have to talk about.